Hello, everyone, and welcome to today's webinar, TDM of Busulfan for Bone Marrow Transplant Patients. I am Peter Harsh for LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Waters Corporation. To learn more, visit www.waters.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. With that, I'd like to now welcome our speaker, Esther Lazo. Esther is the lead medical technologist at Baptist Hospital of Miami.
Hi, thank you, Peter. Welcome to this conference, TDM of Busulfan of Bone Marrow Transplant Patients. Located in South Florida, Baptist Hospital of Miami is home of the Miami Cancer Institute. The Bone Marrow Transplant Project and MCI provide sophisticated and high-quality cancer care to patients in our region and also to patients coming from other countries. In our hospital, physicians, advanced practices providers, pharmacists, nursing, and laboratory staff work as a team to monitor drugs like Busulfan in BMT patients. 2 years ago, the BMT project and our chemistry lab decided to implement the therapeutic drug monitoring of Busulfan in-house for a better management of the bone marrow transplant patients. 2 clinical and financial considerations were taken. First, the analysis of Busulfan in plasma requires a very short turnaround time to determine the optimum dose of Busulfan and to minimize the toxicity of this drug. Second, the reduction of a very expensive and risky send-out testing process. Our management quickly approved the acquisition of the instruments and other equipment needed to support the in-house project. Today, I will present to you the results of the implementation and validation process of our Busulfan testing method. Busulfan is a chemotherapeutic drug used as a component in the myeloablative preconditioning regimen before allogenic stem cell transplantation. Busulfan prevents the immune system from rejecting the new stem cells when they are transplanted. The chemotherapeutic and cytotoxic effects of Busulfan are directly related with the alkylation of the DNA. In clinical practice, TDM is essential for measuring concentration of specific therapeutic drugs at designing intervals in the blood. TDM of Busulfan is critical for determining proper dosage to completely ablate the bone marrow and to prevent the toxic effects. Busulfan concentrations below the therapeutic range put patients at risk of having a graft failure, and Busulfan levels above the therapeutic range increase the risk of transplant-related toxicity and mortality associated with veno-occlusive liver diseases, convulsions, and coma. Busulfan has a narrow therapeutic window, and its exposure and clearance vary significantly from patient to patient. So, the therapeutic monitoring of Busulfan is used to ensure that patients are near to the optimal steady-state concentration. For example, in the intravenous QC dosing protocol, the optimum value is 800 nanograms per milliliter. We use Busulfan in combination with mefalin and fludarabine. As part of the preconditioning protocol in patients, we will receive allogenic stem cell transplant. The first dose of busulfan is given to the patient 9 days before the bone marrow transplant. In the intravenous QC dosing protocol, the recommended dose of busulfan is given every 6 hours for 3 consecutive days. The monitoring of busulfan is done only after the first dose of infusion, and the dose is adjusted according to the area under the curve for the test result. The goal of the busulfan drug level monitoring is adjusting the dose before the 5th infusion. Busulfan Q6 and Q24 are the most common dosing protocols. In the Q6 protocol, the first dose of busulfan is administered for 2 hours starting at 6 a.m. 6 blood samples are collected at a specific time. First one after completion of the first infusion around 8 a.m. Additional specimens are drawn at 15 minutes, 30 minutes, 2, 3, and 4 hours after ending of infusion. The specimens are hand-delivered to central processing in the lab immediately after they are drawn, keeping them on ice at all times. Central processing centrifuge blood specimens as soon as possible, transfers the plasma to plastic tubes, and places in refrigerator with a maximum limit of 45 minutes from the time of collection of every sample. The lab performs and reports the busulfan levels of each plasma sample in nanograms per milliliter. Pharmacy calculates the PK parameters, area under the curve, steady state concentration, and clearance using PK software to recommend the busulfan dose that will be used during the rest of the conditioning regimen. Several factors are challenging during the therapeutic drug monitoring of busulfan. 2 of the most important are the estimation of PK parameters requires multiple blood samples to be taken at specific times, and degradation of busulfan in plasma at room temperature. Potential errors during collection, transportation, and processing of the PK specimens can affect the accuracy for calculation of PK parameters. Some potential errors are sample line contamination, wrong timing, mislabeling, delays in proper storage, and missing information. In the second example, the end of infusion sample could be contaminated with busulfan, and therefore the first point is not fitted in a linear manner with the other time points and affected the calculation of the area under the curve. The turnaround time for busulfan is the time between a specimen collection to final PK report to dose adjustment. Busulfan testing requires a short turnaround time, so clinicians can make a timely dosage adjustment if needed. The turnaround time for the send-out protocol leads to important delays in the adjustment of busulfan dosing. The plasma specimens are shipped overnight to the reference lab. In normal conditions, once the reference lab receives the specimens, they run the testing and verbally call the physician with PK results and dose recommendations. Due to the longer turnaround times, adjustment of dosing takes place before the 7th dose of the conditioning regimen. A send-out protocol requires precise coordination to avoid transportation issues, loss of samples, and others. On the other hand, the busulfan quantification in-house is performed the same day of sample collation, with less technical difficulties, less risks for the patient, and much better turnaround time. The busulfan in-house testing allows pharmacists and physicians to get results faster and to adjust the dosing before the 5th series begins. The quantification of busulfan in plasma needs a sensitive and specific analytical method. Many of the available Busulfan methods are complicated and time-consuming, requiring extensive sample preparation like derivatization in gas chromatography. LC-MS is the most used method in clinical labs to analyze Busulfan concentration in plasma with high accuracy, reproducibility, and simple sample preparation. The LC-MS combines the separating power of the liquid chromatography and the high sensitivity and selective mass analysis capability of the triple quadrupole mass spectrometry. Next, we will describe the LC-MS method for measuring of Busulfan levels in plasma implemented and validated in our lab. Now we have some cool question for you. Does your lab perform TDM testing using LC-MS? Yes. No. Will probably do in the future. No. Other methods are used, for example, immunoassay. It is your lab considering to implement Busulfan using LC-MS? Yes. No. No applicable. The quantification of Busulfan through LC mass spec requires some conditions and materials. Laboratories must consider selecting an optimized LC column to develop a good chromatography method, selecting LC mobile phases compatible with the mass spec and, if possible, with other methods implemented in the lab, using the identification criteria for mass spec in compliance with CLIA and CAP recommendations. Use an isotope label of Busulfan as internal standard to control variation in recovery, matrix effects, and ionization. A sample preparation procedure according to the volume of samples, the matrix effects, and analyze recovery results obtained during the validation. Commercial calibrators are not available. We use calibrators prepared in-house with 9 levels of concentration. Commercial quality controls are not available for Busulfan either. Quality control materials are prepared in the lab or custom-made by specialized companies. Lastly, proficiency testing program for TDM of Busulfan using LC mass spec instrumentations are not available from CAP, LGC, and other organizations. We choose a quick and simple protein precipitation procedure, which removes a part of the phospholipid content present in plasma samples that minimize the analyzed recovery. Busulfan is extracted for 50 microliters of plasma mixed with the internal standard spike in methanol. After centrifugation, 50 microliters of supernatant is diluted with 500 microliters of water to minimize the matrix effects. Then the diluted supernatant is injected onto UPLC mass spec for analysis. The total extraction time of one batch that includes calibrators, quality controls, and 6 patient samples is around 15 minutes. The chromatography separation of Busulfan and the internal standard is obtained within 2.5 minutes using a water-accurate UPLC column and a mobile phase composed of ammonia acetate, formic acid, and water or methanol for a total runtime of 3 minutes. Busulfan and the internal standard are detected in a water SIBO-TQD mass spec using positive ionization, and they are quantified using a multiple reaction monitoring method. We selected 2 ion transitions characteristic for busulfan and 1 ion transition for the internal standard. Quantification of busulfan is performed by plotting the response ratios of the calibrators against the known concentration of each calibrator. The calibration includes a regression analysis to verify linearity. Once a busulfan calibration curve is accepted, quality control samples are in range, and individual samples are inspected for data integration. The patient samples can be tested. Currently, most of the mass spec methods are laboratory development tests, or LDT, which requires an extensive technical and analytical expertise prior clinical implementation. In our lab, validated the busulfan method according to the requirements of CLIA and CAP was part of our work. During this process, the lab must establish the acceptance criteria for each component of the method validation. Combining the chromatographic conditions and the mass spec method, the busulfan and the internal standard can be separated from other matrix components. We use the identification criteria in compliance with CLIA and CAP recommendations about compound identification using ion ratios and retention time. Busulfan and busulfan D8 are separated by their masses difference. The detection is done using 2 ion ratios for busulfan, 1 quant ions and 1 qual ions, and 1 ion ratio for the internal standard. The lower limit of quantification is 20 nanograms per milliliter, and it was defined in our lab as the lowest concentration where the coefficient of variation is less than 10% and accuracy or bias less than 15%. The method is linear over the clinical concentration range of 20 to 5,000 nanograms per milliliter, with an excellent accuracy and precision. Coefficient of variation are less than 5% for all calibrators standards, with an excellent correlation coefficient. Matrix effects and recovery experiments were evaluated at 3 levels of busulfan concentration in plasma. The recovery of busulfan after extraction was more than 98%. We can conclude that the protein precipitation is very efficient for busulfan quantification. We also obtained no significant differences in the response between the busulfan and the internal standard spike into plasma, or busulfan and the internal stand spike into the mobile phase. This is mainly possible because we use butyrated internal standard that compensates the variation during the sample preparation and the mass spec analysis. Matrix effects on analyte ionization can be in both directions, suppression and enhancement. CAP requires the analysis of at least 10 patient plasma samples during the matrix effects evaluation. In our assessment, all suppression enhancement results were less than 10%, meaning the matrix effect does not affect the assay accuracy. Using the MassLink software, we create a graph for routine monitoring of the area of the internal standard. On characteristic deviation of the internal standard, area of the calibrators, QC, or patient samples can indicate an error in sample processing or signal interferences caused by matrix components. The use of a stable butyrated internal standard helps control variability in a quantitative assay. Carryover was not detected in our validation process. We recommend a carryover assessment of every analytical batch by processing a blank quality control sample immediately following the high calibrator. No evidence of analyze must be in the blank sample. We did not detect interference with any several codominant medication spike at high concentration. The precision was evaluated using 3 control samples at different concentrations. In this table, you can see that the average coefficient of variation within run and between run is under 3%, indicating an excellent reproducibility. An accurate quantification of busulfan concentration is the key for effective drug monitoring and maximization of its therapeutic effects. The accuracy was evaluated comparing 124 samples, including patient samples and proficiency testing specimens, with a validated mass spec method. The mean percentage of bias between the busulfan concentration measured with our method and measured by the reference method was 4.4%. This is an excellent result, considering that the maximum acceptable bias for a test performance is 10%. The bias has a correlation coefficient of 0.99 confirms the excellent accuracy of our method. The stability validation studies confirm that busulfan is unstable in plasma and stable up to 6 months when it is frozen. The instability of busulfan in plasma is taken into account in the procedures for collecting, processing, storing samples, transporting samples, preparing calibrators, and quality control materials to obtain reliable analytical data. The precision of the method of busulfan assay is verified with the internal quality control. In this slide, we show you the QC charts for 3 levels of busulfan QC plasma samples. The percentage of bias against the target values for each QC level is less than 5%, a very good precision compared with the clear acceptance limits of 15%. 3 levels of quality controls are included in every batch of samples to determine acceptance performance. Proficiency testing programs from busulfan using mass spec instrumentation are not commercially available. We and others participate in the busulfan cross-verification program organized by Seattle PK Laboratory. Other labs send blind samples to a reference lab that use same methodology to compare results. Seattle prepares a report including the analysis of results of every participating lab compared with the theoretical values assigned for each sample. Here you see how an exact busulfan quantification method affects the calculation of the dose adjustment. The lab 1 did not pass the criteria of acceptance of the cross-verification assessment. The dose adjustment suggested for the lab 1 differs by up to 50% from the one proposed by the reference lab. This is the analysis we did for a specific round of Seattle cross-verification exercise, where the results are compared with the peer mean using the mass spec methodology. The percentage of bias obtained is less than 5% in every proficiency testing sample. The implementation in-house of an efficient and cost-effective method for busulfan provides economic and quality care improvement for BMT patients. The busulfan testing in our labs provides a shorter turnaround time, reduced costs, and eliminates the risky send-out testing process, helping pharmacists and bone marrow transplant groups to get results in a faster and precise manner to adjust busulfan levels before the 5th dose. The results we have presented to you today led us to conclude that we have developed and validated a quick, sensitive, accurate, and reproducible method for the quantification of busulfan in human plasma using liquid chromatography-tandem mass spec technology. Our methodology is reliable for routine therapeutic monitoring of busulfan in plasma samples of BMT patients. This has been a team effort from the lab staff to the physicians, pharmacists, and nursing to the patients. And we work as a team at Miami Hospital and Baptist Hospital of Miami. Thank you very much for your attention. Would you like to speak to Waters specialists on how to can help you to optimize the TDM analysis method? Yes? No?
Thank you, Esther, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. Well, let's start with our first question. What data is used to monitor and ensure assay control? You showed that the absolute area counts are monitored for the internal standard. But what about relative retention time, iron ratios, or other parameters?
We use ion radius characteristics for busulfan, one ion transition as a quantifier, and one ion transition as a qualifier. And also, we select one ion transition monitoring for the internal standard with a transition ratio analysis tolerance within 30%. In addition, the retention time is used in the analyte identification with a tolerance within 1%.
Okay, thanks, Esther, for that. Related to it, what happens when the internal standard area is below their threshold values or falls outside of the confidence interval?
Yes. An aberrant deviation with the internal standard area of a standard QC or other samples could be caused by an error during the sample processing. For example, where you are the tech is pipetting the internal standard solution. A signal interferences in the patient sample that could be another factor, maybe due for the unusual components present in the matrix, or in this case, the plasma. Could be also affected for instrument malfunctions, source errors, something like that. Samples not meeting the acceptance criteria in our say is the deviation of within 25% must be repeated and further investigated.
Okay, great. Looks like we have time for one more question. Has your lab looked at dried blood spots as an alternative sampling technique for therapeutic drug monitoring requirements?
We have not evaluated the clinical application of blood spots using DBS to quantify busulfan concentration. DBS is particularly useful based in some publication in centers using external laboratories to processing busulfan. Or for example, in pediatric patients where collection is the sample is should be difficult
Okay, thank you for that. Well, thank you, Esther. Do you have any final comments for our audience?
Well, we are very happy to be here and share our validation results with all the audience. And okay, thank you so much for your attention. Any questions, please send me to by my email or to the Ronda email that is the chemistry lab managers or in Baptist Hospital.
Okay, thank you again, Esther, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Waters Corporation, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who have missed today's live event. Until then, goodbye.